Our business is predicated on two things: consolidating things that would otherwise be disparate, and then using that as a trusted chassis to communicate and engage effectively.
Hello, and welcome to the Self-Funded with Spencer podcast, a show that cares about healthcare. Each week, we sit down with some of the top industry minds to discuss how this healthcare system works, what solutions actually deliver results for employers, and how do everyday Americans get access to better and cheaper care. So whether this is your first day on the job, or you're a grizzled industry veteran, or if you even randomly stumbled upon this podcast, I promise you that this show is full of information to help you understand this crazy world we call U.S. healthcare. So thanks for tuning in to the Self-Funded with Spencer podcast. Let's go make healthcare better together. Well, so Ryan Coplon, what's up, man? How are you?
I'm great, man.
You're the co-founder, right, of HealthWallet?
Yes, sir.
Yeah. So what is HealthWallet, real quick? Establish what we're going to talk about, and then we'll go into your bio.
Yeah, HealthWallet is a member experience as a service company. We're a benefits aggregation and engagement platform that health plans, TPAs, captives, brokers use to reduce the fragmentation of today's member experience.
So like self-funded plan that you kind of unbundle, and then now you got all these moving parts. You want like a central location to track that stuff and for a member to see what's in their wallet, right?
Yep.
Kind of deal. Okay,
yeah,
cool.
definitely.
Yeah. Well, I know we know this, and we've already had this conversation, but for the folks that are listening, wanted them to have a sense of like, what's today's conversation going to be about? Cool. But I'd like to go backwards like usual in the conversation and kind of learn about you as a person, your work history. I think you have a unique kind of vantage point being a founder of this business, having been a broker in your past life as well. So why don't you run us down your kind of even early days? Where'd you grow up? Where'd you go to school? That good stuff, man.
Split time growing up between the Carolinas and DFW.
Okay. They both Carolinas? Were you back and forth between North and South?
We straddled the line, yeah.
Okay.
So mostly hour west of Charlotte. My dad, he's the last 40-year IBMer left. He's the CTO of digital there, and so Research Triangle in that area and Dallas-Fort Worth are pretty common areas for IBM folks.
So wait, so I don't think I've heard this term of 40 years. Does that mean like an OG when IBM was founded kind of thing?
Well, not founded.
Not founded.
But
when was it? Is that
a while ago.
Okay.
Yeah, longer than that.
Wow.
No, he's been at IBM since before he graduated college.
Wow.
Grew up with the system. Started throwing computers out of buildings and seeing how they fared in the co-op program, and now he's the co-founder of their XO framework and leads their digital strategy globally.
Okay, so his job was sort of dictating kind of the back and forth then, if you will. Okay.
Yeah, his job is definitely going to punch the ticket on the big RFPs, kind of humanizing all the tech jargon, which is funny because growing up, my mom, who's my business partner and CFO, used to be his boss at IBM. Okay. And so there was a lot of technology acronyms growing up at the dinner table.
I would imagine the dinner table was like unusual versus your typical dinner table, right?
It was, yeah, definitely.
What did that, so did that lead you down like an educational path to follow in their footsteps with technology, or no?
In a roundabout way, it did. I was very fortunate to have them to kind of lean on when I decided that I wanted to add a technology element to my professional focus. And so, as a career benefits guy, which we'll get into, I realized that there's a fifth permanently affixed appendage that we all carry around in our pocket every day. And so wanted to kind of leverage that in terms of just the benefit, accessibility. And I knew a lot about benefits and not a lot about technology at the time. And so very fortunate to have them around to kind of steer me in the right direction.
Well, how did you stumble into the world of benefits then at first?
So out of college, my first job was at ADP in their PEO division.
Okay.
And I spent about 12 business minutes there before I realized.
I was going to say, were you going to office buildings and knocking on doors and evading security and stuff like that?
For 12 business minutes. And then that was when I, because ultimately the PEO unit there has a strong synergy with a lot of the brokerage community.
Okay.
And so in sort of cultivating those relationships, I realized that they were having all the fun. So I left ADP and went to an independent brokerage firm in Austin and spent 6 years there, ultimately learning, the benefits of self-funding and captives and, the non-traditional stuff. And so.
Were you producing, or what was
I was.
Okay.
Yep.
So you lasted 12 minutes, you said, in ADP, but
maybe a little longer than that.
Did you like sales though? I mean, it seems like that's probably part of your kind of skill set, if you will.
Yeah. it's a critical part of everything. And so foundationally for me, that's what I aspired to do, mostly for the upside originally. And so, that translated into, running and operating a business here, because obviously to run and operate one, you have to have some clientele.
Yeah. Well, before we transition into kind of HealthWallet and the technology angle that you maybe saw from your world as a consultant, spent 6 years though, so obviously had some success, probably liked it, learned about self-funding and captives and stuff. So what were some of the big takeaways for you having sat in that seat?
That there's a large continuum of insurance brokerage acumen.
Yeah.
And there's some folks that are doing some really cool things in sort of non-traditional, what we call alternative risk financing environments. And so ultimately, we transitioned into exclusively self-funded all the way across the board. We actually had a concept that we called risk finance optimization, which was finding the optimal point of self-funding benefits subsequently on the P&C side. And so we didn't do anything unless it was self-funded. And that ultimately contributed to us deconstructing and rebuilding plans and confusing our plan members more than they already were.
Yeah.
And so,
Well, that is the crux of this whole unbundling movement, right? Which is not necessarily, it's not a new idea to unbundle your self-funded plan and add point solutions, but I think it's growing pretty significantly in popularity.
Okay.
What we do as a captive, allows for the smaller employer to do that.
Definitely.
But the other side of that coin, of course, is how does the average member then engage with their health plan when you have all these moving parts that they don't understand, or they may not even know exist, right? And so did you start to recognize that as a consultant, that it was creating confusion amongst the population?
So I had an aha moment at a group captive member meeting when we were doing utilization review of all the cool shiny toys we brought to the table as consultants. Mm-hmm. And what we ultimately realized is with just ineffective communication and lack of accessibility, that contributes to underutilization and subsequently egg on the face of the consultant.
Yep.
That contributed to the expense ratio of the plan to bring the shiny toys.
Was there a specific employer? You said it was an aha moment. I mean, you don't have to name the employer, but was it actually a single aha moment that happened, or what?
Well, our captive at the time was very programmatic. So same vendor ecosystem, cheeseburger. So it was a handful of employers where, we laid the infrastructure for the plan in a way that we as the strategy folks knew that the plan and the members could benefit if used harmoniously. And there was no harmony at all. And, Sally did the same old thing with the same old doc.
Yep.
And that was a byproduct of ineffective communication and lack of accessibility. And so
Yep.
I bet my career on the fact that we weren't the only consultants in the self-funded space that were having that problem.
No, you certainly weren't, man. What time frame was this when this happened? About
2016?
2016, okay, yeah. And I think everything you said is true about the possibilities with a really well-designed plan, but it's predicated on the notion that the average individual knows how to use it, right? So you can have optimized construction of a plan, but if people are confused or unaware, everything I just described, it's gonna fall flat, right? And it actually might even perform worse as a result, too. So then when did you get to a point where you go, not only do I see an opportunity here, but I'm going to go all in on this instead of maybe trying to do it as a side hustle or something like that?
Yeah, so originally we built it for our programs and groups. And when I saw the adoption, just the market adoption within our little sandbox, I saw it working the way that we anticipated it, and then realized that just from a business standpoint, this was a way for me to do something that was far more scalable with far less, and there's a need that I can address that ultimately can touch much more than we're able to do just self-funding benefit plans. And we can work with the folks that are self-funding benefit plans instead of doing it ourselves, group to group to group to group.
Well, that's the trade-off, man. I talk to consultant friends all the time. It's like they get, in you as a consultant in your past too, you get tangibility. Like I get to work with this employer. I get to help them improve their bottom line and help them optimize their health plan. So there's a tangibility component. I exist kind of a layer up in the captive space, which is I sell into those type of consultants and it trickles down, whenever it applies. And so I don't have the same level of connection with the employers always that you might as a consultant, but there's a scalability that's possible that is not necessarily as possible with the consultant,
100%.
right? So that's the trade-off, right? Is I don't get to see it firsthand as much as you might get to do. However, the ability to potentially influence more over time exists because of that layer. Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, 1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has two distinct parts. Number one, to make self-insurance simple and more accessible for small to mid-sized employers. And number two, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale. So then I think one of the other comment I'll make before we get into like kind of the standing up of the business, a common theme I have heard amongst entrepreneurs, and I've sat down with quite a few, is it usually starts from solving your own problem first and realizing there's a market for that, right? 100%. So it kind of sounds like that's the same story with you as well. So how long did you sort of bake it in your own population, if you will, before you started to go out to market?
About a year and a half. Okay. So through a full plan year, and we were fortunate that we had the membership that we were able to sort of incubate HealthWallet out of. And so it was very much a iteration number one, iteration number two. And it was really build, ask, build. I mean, because we had the relationship with the employer groups, we were able to get feedback and sort of beta test what they thought worked and then implement. And I was very fortunate to partner with my co-founder at the time who owned a mobile app development firm already. So from day one, we had a mobile team that was already working together on projects for 10 years. And we had customers day one. And so those two things created an environment where, unlike, not just even competitors of mine, but like folks in the software space, we didn't have to, fundraise and do all those things because we had a captive audience, no pun intended, and a very competent development team. And so those two things, working together for about a year, I realized that, there's a addressable market that's far beyond what I'm going to be able to touch group to group to group. And well,
you kind of answered my question. I was going to say sometimes when it comes to technology, you can buy, borrow, or build, right? Yep. And so did you look at the market first to see if anything existed that served this function first? Or if you did, maybe was it just leaving you wanting if something like that did exist? Or did you know immediately that you're going to build it?
Yeah.
It sounded like you had the infrastructure already in place to easily execute on it, but there's always that value trade-off again. It's like, do I invest in this and build it myself, or could I source it or license it somewhere else as well?
So our firm used vertical integration as a strategy, and so we definitely had what we'll call like sidecos, for lack of a better way to describe them all collectively. And in some scenarios, we're eating our own dog food a little. I mean, we had the distribution in order to, incubate things out of that. We had a pharmacy benefit aggregation entity for a while that, we vertically integrated into all of our groups. So at the time, I didn't actually have any clue that it was going to turn into what it has, because it's so different than it was back then, but it was always intended to be one of our projects.
Sure. No, I like that, man. And there's a couple firms I know of that have their own sort of technology arm or built with a technology first kind of basis.
Yep.
And it makes sense as a strategic advantage, right? To be able to offer something that the rest of the market can't get access to at the time. So then when did you, or actually no, the one question I want to ask is, surely you learned some things building this from scratch, right?
Oh, yeah.
So like, did anything just like monumentally not work before you went to market with it that you can think of?
Well, I was very fortunate to be able to take to market something that was my market. And so, we sort of absorbed it in the administrative expense of the plan in the beginning. And so we rolled it out and reiterated. So over the past 7 years, there's been hundreds of scenarios where things didn't, go as planned. But I've run this business like I ran the others, which is sort of like, not the way it goes in the software world. Mm-hmm. We ran this business originally to make a profit. And we didn't take on a ton of money before we ever put any on the street and have a bunch of private equity investors and all that. And so because of that, we've been able to perpetually reiterate, refine, run around the roadblock, smash it again. Yeah. So I'd say really the thing that we learned, and I joke about this all the time, we touch tons of TPAs, brokers, payers. The joke that we have internally is everybody's got a brother-in-law at a virtual care company. So what we decided to do was to go platform as a service and be vendor agnostic. Okay. So what really helped us is, I hired a dedicated engineer that specifically integrates third-party point solutions by request of our partners, whether it's a TPA or a broker or a payer, because they either have an interest in a wellness company, telemedicine company, network, so on and so forth. And so instead of curating a suite of vendors and trying to take them to the market in sort of like an aggregated play, we decided to try to perpetuate the strategist strategy. And,
Well, that's it. We operate with sort of at a similar level of agnosticism, if you will. Like you mentioned a captive that you worked with before, that was more programmatic in nature and required a certain vendor set. I certainly think there's an argument for that in certain circumstances, but what it does do, in my opinion, is limit the scalability or the receptivity to it, because you're already dealing with something that's relatively complex of going self-funded, especially a smaller employer. Then you're like mandating all the things that they have to do. And so to me, that's just limiting the potential buyer set.
Definitely.
And so what we've done, and it sounds like what you did as well, is be agnostic about those partners. Maybe you have preferred partners or ones that can handle volume and things like that. Yep. But at the end of the day, the choice is still left up to the employer and the consultant to build whatever plan they want. And I think that that flexibility allows you to scale faster. For sure. So when did you actually go to market externally? Do you remember kind of the day when you turned the lights on in this business?
Yeah. So at the time, we were generating quite a bit of revenue for our TPA partners at the time.
Okay.
And so the old do business with us, we'll do business with you kind of play was when I first decided. There wasn't a clear line of demarcation where we turned the lights off and went outside. Yeah. It was really the TPAs that we worked with had implemented this because they're doing the administration on our groups. And then they started wanting to take it outside of our groups into their groups. And so
the demand was pulling you to the market.
Yeah. And so that was when I realized,
So what'd you do with the interest in the firm? Did you guys have to sell the firm? Or?
I sold it to my partners, who then sold it to Acrisure.
Okay. So then you're done with the consulting business altogether at that point.
Yep.
Okay. So then you start to go to market. What are some of the things that you discover early on? You find out about like the application for it or who's wanting it, that sort of thing.
I found out that there's a lot of folks that thought that there should be something like this, and there really wasn't at the time, or at least like not in an overly prevalent way. And the common denominator was I'm able to tell them the same story that I personally experienced, which was, you're administering all these really great self-funded health plans that have all this cool stuff, and aside from just like lack of communication, accessibility, which contributes to underutilization. What it also does is it creates an environment where you're curating all of these, we'll call them point solutions for lack of a better way to describe it, or infrastructure in a health plan, and contributing to the expense ratio of the plan. Underutilization leads to egg on the face of the people who put it there. And so we just, realized that with the problem that we experience in the market, all of our peers are having some flavor of that problem. And so, the thing about us being so flexible and modular is you could have two HealthWallet member experiences if set down on the table next to one another that would be functionally unrecognizable.
Okay.
So we very much play the, member experience aggregation and then using that as a chassis to then more effectively communicate and engage perpetually throughout the course of the year. And where I did have an aha moment though, because there's the obvious application, again, no pun intended, of what we do in driving utilization and optimal care path and steerage and that sort of stuff. But what it also does is it relinquishes high volume, low complexity service burden for member facing service units.
Okay, so explain that. Yeah.
So there's a handful of organizations that we work with that are TPAs that have a sister company or somebody that they work with that's the navigation unit. Maybe they're the navigation unit also operating under the guise of like member facing services.
Sure.
All things. So they sort of championed us coming to the party in some of these self-funded health plans because when they look at, let's say their access point for membership is telephonic and email, just for purposes of discussion. If they look at all of their annual instances, 60 to 70% of it would be inherently self-service through a mobile platform that has just the regular nuts and bolts of what we do.
Okay.
And so that allows member-facing service units to focus on the high complexity stuff, not so much the where's my ID card, what's my deductible, is my provider in network, do I have health insurance,
It's almost like I'm trying to picture like a basic analogy, but you know how like people will get like I'm wearing one today, but like a jean jacket and then they'll sew patches onto it and they'll like put together their custom patch jacket.
Yeah.
It's almost like you guys are stitching that all together for a plan,
Very
whatever
much so.
patches you choose to put on your jacket to become your own customized jacket.
Or they choose.
They choose to do it, then you allow them to be able to do that. And so what I think it does is in the world we're in today where you're disassembling a health plan and then you're trying to get it to function like what you left, the simplicity or ease of a fully insured plan, but you want to reassemble it with moving parts that are supposedly or hopefully better on their own, but they're only really good as a comprehensive solution if you've stitched it or tied it all together successfully so that it functions to the member exactly like they just left or better, right?
Exactly.
You want it to be better, but you don't want to be more complex or harder to navigate or any of those things. And so that's what this category of what would you even call like HealthWallet's category? Has the market dictated what this category is called?
I mean, we call it member experience as a service, but it's really benefit aggregation and engagement.
Okay. Benefit aggregation and engagement. I think that's a good way to position it. But why don't we take it down a layer, Ryan, and say, who's this for, right? So I think presumption is it's a self-funded plan, right? Or can a fully insured group still benefit from HealthWallet?
Yeah, they definitely can. So I'd say 75% of our business is in some form or fashion a self-funded plan of some sort. Now, that varies drastically because it's either major medical or it's not. If it's not, it's a universe of things: MEC plans, limited medical plans, cost share programs, non-insured capitated benefit solutions, whatever. But we serve a brokerage community that isn't always exclusively self-funded.
Okay.
So the value prop in that environment is consistent front door, regardless of the carriers.
I see.
So we're integrated through several of the clearinghouses with over 90% of covered lives in America, meaning we're pulling down real-time accumulators, plan design info from all the major payers, all the BUCAs, tons of independent TPAs because they're in the Change and P-Verify and some of these other like interoperability environments. And so brokerage firms use us even on the fully insured stuff as a engagement solution to where even if the group moves to Blue next year from Cigna or whatever, HealthWallet can stay intact. We flip a switch, change the carrier at renewal, and their experience and accessibility is the same regardless of,
Are you guys getting claims data as well?
Yeah.
Okay. Are you getting claims data on the front end or after the integration? Like, are you able to help a new client pull down maybe some pre-existing claims data from their previous plan year or no?
Yes.
Okay.
Yeah. It just depends on from where.
From where?
Yeah.
Okay.
So some of the payers have availability of that data. We have some integrations with some folks that do like some EOB harvesting.
So scraping,
Yeah. So that's kind of cool. That requires some, like member participation, of course, but we certainly do. And then, we get into a lot of, feeding into certain analytics platforms.
Yeah.
And so, that's
what a lot of plans sort of lack a centralized conduit for the claims data itself, right? Because that claims data is useful in a data analytics platform. It's useful for the consultant. It's useful for the employer. But like centralizing that receptance or the receipt of the claims, especially if medical and pharmacy is carved out, and then distributing elsewhere where it needs to go for analytics purposes doesn't always exist, right? So like that's a challenge in and of itself, is how do we get that data and then how do we disseminate it properly? But I want to go back to your like specific use case, and let's focus on the self-funded plan, since that's what we obviously do here. And so types of groups, like TPA versus ASO, pharmacy carved out, carved in. Like, talk to me about like a typical use case for you guys.
Yeah, I'd say we focus predominantly in sort of the independent TPA world, because that's further along down the self-funded continuum. There's definitely crawl, walk, run in this world.
Sure.
And so that's where the member experience fragmentation issue has perpetuated itself, because in that world, independent TPA means TPAs mutually exclusive from the PBM, from the network, from the virtual care, from the so on and so forth. And so we tend to service, independent TPA style self-funded groups, tons of program type business, captives. But it really varies in terms of sort of how far they are in their self-funding journey.
Is there anything that's like too far for you guys, or that makes it difficult to do on that continuum, or no?
I'd say the more complex, the better.
Okay.
Just because the problem that we set out to solve is worse in that environment than it was, earlier in the self-funded journey.
Yeah, your bundled sort of Blue Cross self-funded plan doesn't have the same level of same level of complexity, if you will, that needs to be solved.
And so just like disparate access points for members.
Yeah.
And so, we do a lot of stuff where, like to your point a minute ago, you have the data nucleus at the plan level, which is giving you, great insight forward and rearview mirror about population level risk stratification and what levers to pull and this and that. That requires behavior change. And prior to that, some sort of timely engagement and communication. And so a lot of the reason why we work with the independent TPA community is because the data availability and their ability to leverage it. And so we work with them to build instance-based engagements, like automation logic, where maybe if they send through eligibility a flag that this member's now in pre-auth, pre-cert, we've already pre-configured what care coordination wants to automatically say to them via a push notification.
Oh, really?
Right now.
Wow. Okay.
And, it varies drastically. And again, we say we perpetuate the strategist's strategy, so they may have a different strategy than some other folks, but the timeliness and the ability to get out in front of those things ultimately makes the data actionable instead of just available.
Well, that's a great way to put it. Actionable instead of available, because you have to intervene at some point if you actually want to course correct, change where the member goes, any sort of steerage, any sort of care navigation. If you want to solve the price problem, then you've got to be able to intervene prior to the consumption of healthcare. Otherwise, you're scrambling to try to claw back or something at that point. And so that timeliness becomes absolutely crucial. Having spent years working alongside healthcare leaders, brokers, and employers, I know how overwhelming healthcare can feel for our customers. We've all been there. Those renewal conversations that never seem to get easier. Rising pharmacy costs and medical costs, and no real transparency into where healthcare dollars are going. That's why I'm excited about Nomi Health. They're not just fixing the old system. They've rebuilt self-funded benefits from the ground up. With Nomi's network, you can offer something truly different. No copays, no deductibles, zero out-of-pocket costs when members see a provider. It's the kind of benefit that makes everyone ask, why hasn't healthcare always worked this way? Ready to bring your clients something different? Visit nomihealth.com and see how Nomi is rebuilding healthcare, one employer and one community at a time. So are we talking about almost instantaneous response when that flag comes up for you guys? Or
what?
Okay.
So our business is predicated on two things: consolidating things that would otherwise be disparate, and then using that as a trusted chassis to communicate and engage effectively.
Okay.
And so, it varies drastically in function in terms of like how and when and what we say and whatever. And a lot of times that's sort of collaborative with our administrative and brokerage partners. But yeah, I mean, we have geo-perimeter based engagements. We have, we've built a lot of like automation logic around the example I used a minute ago where if this particular plan that they deconstructed and rebuilt always wants to communicate something via care coordination to somebody who's been referred or is in pre-auth pre-cert, or, our platform's capable of doing it immediately.
Is that via text or via the app itself?
Text, email, and push.
Okay, right on. Because you gotta be able to meet somebody. If time is of the essence, you got to be able to meet them where they are right away and get a hold of them, right? Okay, so who would you say is more of your kind of clientele mix? Is it more TPA driven for application for this, or is it a lot of it still going through consultant distribution too?
Well, where there's a self-funded group, there's a consultant.
Yes.
And so.
But in terms of making the recommendation to explore a HealthWallet, is that typically still coming from the consultant then, or?
What I've found is being a recovering consultant myself, I can certainly speak the language, and we have met a lot of TPAs as a byproduct of an introduction from a broker.
Okay.
Personally, I've focused most of my time anyway on the business development side in the TPA space, mostly because that's a more scalable model for us.
Yeah, makes
because
sense.
they operate on a consistent data nucleus and like one administrative platform. Whereas if we're working with a broker, it's very rare that, all of their self-funded groups are on one. So we're installing group to group to group to group. Whereas we set up a deal with a TPA. I mean, they could process a new file that has 100 new groups tomorrow, and we even knew about it.
Okay, that's awesome. Yeah, and that makes total sense. I'm just trying to get a sense of the distribution mix that you guys have. But you called it a member engagement and aggregation platform. So let's talk about the member experience itself, right? So I'm average Sally or Joe that finds out my company has provided me access to HealthWallet. What does it look like for me? What are the main things I'm using this application for?
Well, and so we actually, the way that you found out about it is because part of our process is doing what we call digital fulfillment, which is effectively outreach. Mm-hmm. So our platform, makes it hilariously easy to find for members. And then once they authenticate, the member experience, I would say, ultimately runs on plan-related information.
Okay.
So, accumulators and plan designs and emphasis on any incentive like tiered benefit design or reduced member responsibility for some stewardship of some sort. Integrating what would otherwise be like what we call tertiary point solutions. So like virtual cares integrated, pharmacy benefits integrated, EAP oftentimes, mental behavioral. But it's a very intentionally big, unmistakable buttons by design, right? Because what we're doing is we're trying to make complex simple. And
while you're saying that, I'm picturing, you remember the old jitterbug phones that were designed for the elderly with the giant buttons?
Well, and so, I'd say it's in that swim lane for sure, but it's by design because, you and your audience and everybody in the business knows so much about. Yeah,
but you and I are joking about this, man, that we're both kind of bad consumers of healthcare ourselves. And I'm the first one to say that, right? So it's like, it's crazy. You think, we must know everything about how to navigate the healthcare system. The reality is I need guidance through the entire chain myself, even doing what I do.
Exactly.
So I don't mean to be tongue in cheek about, joking about the jitterbug. It's like, it does need to be that level of simplicity to be effective, for sure.
And I feel like there's a direct correlation to engagement. Well, to ultimately get the benefit out of the engagement needs to come with the action. Mm-hmm. It needs to provide them not just information about the solution, but like how to access
what to do.
Yeah. And ideally, in most of our scenarios, we've done thousands and thousands of integrations via single sign-on and APIs and all that, because we want them to be able to access the services in our platform and not have to go anywhere else.
Okay.
And that's just, for purposes of making it easy to use, because if they get the push notification, this is obviously a hyper generic example, but allergy season's coming around, don't forget virtual care's free.
Yeah.
I'm just using a watered down example.
Yeah.
it would be ideal if when they touch that push notification, it takes them into the virtual care environment instead of just benefit information.
Yeah. No, it takes you. It almost completes the next step for them right away. Right, that makes sense.
Yep.
And so, like in terms of main benefit to average member, like where are they deriving that? Is it access to the virtual care? Is it just having everything in one single spot? Like, what is that to them? What's most important to a consumer? Okay.
Yeah, it's having everything in one spot, because nowadays, without a kind of what we call like the benefit nucleus, it's just a fragmented member experience. I mean, they have 5 new apps, many of which they don't know about. We joke all the time that they're going to read the fire extinguisher label when their hair's on fire. And
right.
It's going to end up in member-facing services because do we have telehealth? What is telehealth? I'm just using that as an obvious example.
It is actually the dynamic, especially at open enrollment, is to presume you can build this type of plan and spend an hour with your population going over it and have them remember 95% of it. They're going to forget most of it, right? Yep. They're going to go to how much does it cost? Did my deductible change? Oh, I heard about this shiny new thing we have, but quite frankly, I forgot what it was. And then they move on with their day until they're in a desperate situation and they actually need help.
That's right.
So like, how do you intervene and prevent them from sort of like in one ear and out the other and forgetting about what you do?
Yeah, good question. So what we've started doing over the last, probably 2 years or so, is doubling down on the engagement side of the sort of business focus. And so a practical example that we've been doing these days is like, let's say, well, here's a good example. So we have some brokerage partners that we work with that they're on the very progressive side of the rebuilt health plan continuum. Okay. It's like optimal care path only and this and that. And so we ask them, give us the 5 member facing nuances to this plan that you definitely want to make sure that you emphasize.
Okay.
And then we've started taking that, turning it into engaging content and putting it into places within the member experience that makes sense. So like, I'll give you an example.
Yeah.
We have a TPA client that has a reference-based chassis with a direct contract on top. And if you go to any of these facilities, it's totally free, right? Mm-hmm. It's a panel of preventative and imaging and primary care. And so what we did is we built a micro member experience for them that is, instead of putting the onus of consumerism on them, it's free healthcare in all caps. Here's all the things that could be free. Yeah. Do you want it to be free? And if they say yes, then it FTPs over to care coordination, who reaches out, schedules care.
I see.
If they say, I'm not sure, then we pop up. I asked this TPA broker, what's the optimal thing to say to this member right before they do the wrong thing? We turned that into an explainer video, embedded it within the platform at that part of the journey, right next to their remaining member responsibility in all bold and caps. And says, are you sure you still want to pay for this? If not, and so kind of watering down the
that's like a lawyer kind of leading a question to get to the answer they want, but you're still asking the question, right? Do you want to do this, right? So it still feels like it gives them choice in the matter. And if Sally loves her doctor and is willing to pay the copay to go outside of that tier 1 network arrangement and pay for it, she has the choice, but you're making it abundantly obvious that you're making that choice at that moment,
right.
But you're sort of leading them to make the other choice. You want them to make the other choice. So the incentives have to be constructed to encourage them to make that other choice.
And effectively communicated.
Yes.
Yeah, because what I've learned about, ultimately as a byproduct of running this business for as long as we have, we're sort of, we play the role of trying to help people change their members' behavior, right? So we've had enough at bats at learning, what makes them do it and what doesn't. And common denominator is they're interested in what's beneficial to them, not their employer or their plan sponsor or their insurance carrier, right? Like they might change their behavior if it's free or cheaper or more convenient.
Chronic health issues, surprise out-of-network medical bills, inflated medical and prescription drug prices. These issues cost self-insured employers hundreds of millions of dollars every year. Add to this the rising cost of care and potential for waste across the life of a claim, and it's clear that self-insured employers need innovative solutions that lower their health plan spend. At Valence, we've done just that, developed innovation that shifts the current paradigm. A complete and integrated ecosystem solution driven by data, one that manages and simplifies the complexity of medical claim costs. It is through analyzing millions of data points that we enable employers to realize and fuel cost-saving solutions. Valence experts come prepared from day one, targeting the fraction of claims that will drive the majority of health plan costs. That is how our team lives the Valence promise, engaging early and often for smarter, better, faster healthcare.
But those two things do coalesce, right? So yeah, I get it. You're going to meet the individual where they're at and get them to act based on their own personal incentives, right?
Correct.
They're thinking about themselves.
That's right.
The layer above that, though, is those choices, if done in aggregate, benefit the plan, which then in turn benefit them at next year's renewal when the contributions stay the same or go down,
That's right?
Or the premium holiday gets offered in December, right? So you can make people act in their own selfish interests and still do so in a way that benefits the whole as well.
And that's the folks that we work with and that you guys work with that are very intentionally deconstructing and rebuilding these plans in a way that with certain stewardship behavior, it is beneficial to the member and the plan sponsor simultaneously.
Right.
That is the reason why, it was deconstructed and rebuilt the way that
Well, then that's the same thing. I've said it before, but I'll say it again. Is like you can have a health plan that actually lowers in costs over time and improves in quality simultaneously.
Sure.
Most people think those are mutually exclusive. What it sounds like is a health wallet is sort of empowering that to be possible, right?
Yep.
You've made the right step as a consultant to build a strategy that's designed to deliver lower costs, but now you need to execute on that strategy.
Right.
And if you do it, the quality of care and the quality of experience can also go up at the same time.
Definitely.
Right? And I think that's the new paradigm that we're trying to construct in healthcare. Whatever version 3.0, 4.0 we're on right now, it's like you can have those two things simultaneously, and that should be the expectation. That should be the standard. And I think we're still trying to convince employers that those things are possible. They just have to make a better decision to start,
Yep.
right? To start down that path. Okay, so why don't we do anything we haven't covered though, because I don't want to move on from HealthWallet, but you and I are going to do an exercise here in a minute. And I think it'll be pretty beneficial to the audience. But what have we missed on the conversation about HealthWallet?
I think fundamentally, the reason why folks do business with us is our flexibility and modularity. So I like to, there's really two reasons. It's the flexibility and modularity. So we're perpetuating the strategy of the strategist.
Okay.
And we're not necessarily, trying to impose anything that's not theirs already, more or less. And then circling back to growing up in a technology family, I was very fortunate to start the business when I did with the people around me that I did, because what that translates to in this world is being, from the horse's mouth, definitely the easiest to implement.
Okay.
And that's a byproduct of us normalizing data into our specs and allowing them to provide it in whatever format they're capable of providing it. And we learned that through asking TPAs to do things in Q4. And so, if there's anything that's really led to us having some great traction, it's being easy to work with and sort of taking previous knowledge and experience of how the self-funded health plan ecosystem operates into relationships with TPAs, and then learning from those what translates into relationships with other ones, and just in terms of operating infrastructure.
Yeah, I think you should always sort of like aim to get better at execution, and that
Right.
sounds like the speed of execution is a crucial component of what you do. And it actually leads me to another question that I do want to ask is like, what's a typical timeline? What sort of expectations? Let's say I'm a consultant right now listening to this, and this HealthWallet conversation is very compelling. I've got a group in mind. When should I start a conversation with you guys to get it rolling?
Yeah, so obviously
There's ideal worlds and there's real worlds. I get that, right? But like, what would be your, hey, is this an on cycle kind of conversation at renewal date? If so, how far back should we be having conversations, things like that?
Well, it definitely doesn't need to be on cycle.
Okay.
Oftentimes it is, just because that's when things move around.
Yep.
We do a lot of implementation that's not necessarily on cycle, if for no reason other than everybody's scrambling for 1/1 and then throws their hands up and goes on vacation. So sometimes we'll do 2/1 for 1/1s or whatever.
Yeah.
But 30 days is more than enough.
Okay.
Unless we're doing like a full build, which we have several pure private labels. HealthWallet totally de-identified. under their brand, that's a different deal.
Okay, yeah.
But standard, commercial employer group business, we need less than 30 days.
Okay.
And I say that knowing that it could take a lot less than that, but I can feel my ops team wanting to stick a fence post in my back by saying anything, making any representations that are faster. So 30 days is more than enough.
Well, and with something like this in this category, as you define it, I'm getting to the conclusion, and I've obviously featured other folks in this category as well before. I'm of the conclusion, I want to see if you probably agree, is that this now needs to be just sort of like table stakes almost, and not to diminish what you do, but I think it should be a given that this is part of any self-funded plan that's unbundled. Do you think that's fair? I mean, you have incentive to say that, but I'm coming to this independently. We're a user of another platform ourselves at Pareto, but I think it's just, it's a necessary component in today's world.
Yeah, it started as, sort of on the progressive side of the continuum, and it's now sort of like, well, let's put it this way. We get a lot of business out of, or new like brokerage and TPA relationships because they've seen our stuff in a competitive RFP. So it's very much like, if you're rebuilding self-funded health plans and you don't have a member experience element to it, then you're losing out on something that.
Well, I would say especially, and we don't have to get into specific pricing, but especially at like kind of the price point that it's positioned at versus their total health plan expenditure.
Oh yeah,
it's nominal, right? And so therefore, you'd almost have to come up with a really strong argument why you wouldn't do something at this point, right? Especially as a fiduciary. Like I would look really hard at why I'm not doing something like this. And you can pick which one you want to use, but I think if you're not deploying a solution in this category these days, you're probably not optimized as a plan, and you're losing dollars. You're probably losing people because of bad experiences. The consultant could potentially be at risk because even if their strategy was great, it wasn't executed on to its optimized form. Blah, 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 right? We're at this point, I think this is the world we live in. And so are you anticipating sort of that light of sort of marketplace growth in your category? Okay.
Well, what's interesting too, and it's like everything else in the world has gone paperless, but TPAs still spend hundreds of thousands, if not millions of dollars a year on print and mail for ID cards and EOBs. Half the time it's the wrong address, so they mail it twice.
I can't imagine we're still in a world. I mean, I have a physical card in my wallet, but in most of the time people want to see it, right? You're at the doctor's office, but like, it seems like we should have been able to move on from that at some point.
Well, and a lot of our clients have. So aside from just like driving utilization to justify our existence, there's the driving utilization play. There's the reduction in member-facing service unit or the increased capacity for care navigation teams. But then I had an aha moment a year ago-ish, and I went to a handful of my larger TPA clients that do more non-traditional medical plans, like MEC plans, limited medical plans, cost-sharing plans. And I went to them and said, why don't you just do digital ID card and EOB unless the member specifically requests physical upon enrollment? And they're like, well, I don't know. Why don't we?
Why don't we?
And so like one example is we have a 300,000 life MEC plan client that has less than 10% opt-in to physical. So, and they, as the TPA, were absorbing the print and mail monthly expense for all ID cards and EOBs.
Yeah.
So if they want it, give it to them. If they don't give it to them.
They just save 90% on cost, but by one question.
Well, and that TPA, that was 130 G's a month of house money that we justify our existence with.
Yeah.
And so that was just like a kind of an obvious one. I don't know, there's the compliance folks on the major medical side that they haven't been as progressive with digital fulfillment, exclusively.
Yeah.
And it's not exclusively because they could always opt in, but it's a much faster thing that we see over on the.
Well, not to mention like just having the choice between a physical card, a laminated card in my wallet, or a HealthWallet digital app.
Yep.
You're driving them to the place you want them to be by getting them to go to the digital one, right? If you have the physical card in your wallet, you're going to operate on the same behaviors that you've always operated on because nothing is screaming at you to tell you have a better decision that you can make.
That is our favorite play in the playbook to drive activation is our first communication is generally via text and email, because obviously they haven't authenticated into our environment yet, so you can't send them a push notification yet. But the availability of their digital card compared to their physical card in limbo between plan renewal and when they actually get it, we hammer that because that does drive activation.
100%.
And then once they activate, then we can engage them the way that we intend to.
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans, and allowing them to create an environment where we ensure that the benefit plans are being charged on a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
All right, so let's do the exercise now, Ryan, that you and I were talking over coffee that I've kind of always wanted to do. And this is theoretical, conceptual. Nathaniel, maybe we'll turn this into like a longer clip. But what I want to talk through is because your experience setting as a consultant and building these plans, and then with HealthWallet helping reassemble them, is you probably got a pretty strong opinion of like, if you could build a perfect self-funded plan, what it would look like. And let's remove geographic limitations, size limitations, kind of if we had no constraints on building the perfect plan, like what would you do, right? So let's start at the kind of the foundation of any health plan. Let's assume they're self-funded, independent TPA, independent PBM. What does primary care look like in your mind? Let's start there.
Well, assuming that we've gone through the crawl, walk, run phase, we're
running now.
Destination,
we're flying.
optimal.
Yeah.
I think that we've done away with the Buca rental network.
Okay.
That usually sits there because the HR folks are worried about the disruption that comes from
my doctor's out of network.
All that,
yeah.
Right?
Yep.
So it would definitely be a reference-based chassis for the catch-all.
Okay.
Right? I mean, unless you just want to totally restrict it and change the way that people access care to exclusively through, what we call the optimal care path. But I think ideally, just to catch all the oopsies, there's a reference-based chassis of some sort.
Okay.
There's a value-based provider arrangement in primary.
Okay.
So that's either an at-risk provider group, maybe locally, because it's pretty difficult to assume that you're going to have a nationally available value-based care arrangement.
Fair.
Right?
Fair.
So we'll call the first stop on the journey either a blend of direct primary care and value-based.
Okay. And value-based means that kind of the provider's at risk for performance, right?
Yeah, and there are ways to structure those contracts with the providers where they financially benefit by playing ball, right? Instead of doing standard fee-for-service, ring the cash register style primary care, when they are in an environment where they're sort of at risk, and I use that on the negative side of it, with upside on the positive side of it for just general population healthcare adherence, then they can kind of be the front door liaison between, when the member goes in for the first time for whatever they're going to go for, having a pre-auth and referral directive into care navigation, care coordination, whatever you want to call it, medical management, that then can deal with the heavy stuff.
Yeah, because primary care can function for a very large subset of the healthcare delivery ecosystem, but mostly non-emergent, right? Not specialty care, things like that. And so I agree with your sort of basic premise that the foundation is some version of a direct primary care, a fee, monthly fee model. Value-based makes sense if deployable at scale, but may not be depending on where the population is.
Could be regionalized.
Could regionalize. You could have a virtual component. You should have a virtual access component as well. But then assuming, okay, now we've got something that a primary care physician cannot take care of. How do we connect the dots between that and a specialty care or something of the nature of a pre-scheduled procedure, imaging, those kind of things?
Yeah, so you can catch all the traffic if you mandate that the plan goes through pre-auth, pre-cert, and the referral directives come to whoever your dedicated care coordination unit is. And then obviously, from there, you're getting into centers of excellence and bundled payments and maybe even a little flavor of medical tourism if there's some real incentive to do something somewhere else.
Like domestic or even international tourism, possibly. Right?
That might be on the hyper progressive side of the continuum, but I mean.
But what's the goal? Is get them in the right place.
Yep.
Get them to a place with an optimal outcome, or at least an optimal probability of a good outcome. You can't guarantee it with a surgical procedure. And then costs, right? Knowing ahead of time as much as possible how much this procedure is going to cost the plan, and then incentivizing the member through plan design, waiving copays, things like that, deductibles out of pocket at all, potentially, so that they make that decision, right?
And I just feel like members, because of the way that you architect the plan, they're not going to interact, at least like in the aggregate at scale, they're not going to interact with care coordination prior to a primary care instance. Mm-hmm. They're probably just going to go to primary care. Now, if you communicate it the right way and incentivize them somehow, then there's a chance that they do. But I feel like, primary care and even, unfortunately, urgent care are sort of like the front line into the healthcare journey. So if you can have some arrangement where you can generally control what happens after primary care, meaning maybe cut it all off unless it goes through care coordination, who can then manage the heavy stuff and, that's really how because you're not going to, at least at scale, I don't think you're going to really change too much primary care behavior unless there's like serious incentive to do so.
Yeah.
And you can do that through either just making that the only option or, by design, making there a strong difference in member responsibility. Maybe like completely eliminated and making one higher than it would otherwise be.
Yeah, I think I've heard the term used tier and steer, right?
Yeah, tier and steer.
So you have like a narrower network that's the tier one network with these sort of pre-negotiated contracts and bundled surgical arrangements and things like that, with the waiving of the out-of-pocket for the member. They can still go to what you would call a tier two network or outside of that tier one, but normal copays and deductibles and things like that will apply. And then you have to have some sort of payment methodology, whether that's a wrap network or whether that's a reference-based pricing arrangement like you were describing, right? But how does a smaller employer on the continuum, they don't have the leveraging power to go negotiate a direct contract with the hospital system?
Probably not.
Right? Okay. So you're saying a reference-based pricing arrangement sort of replaces their ability to maybe not be able to do that?
Or join an aggregate.
Okay.
Yeah, because for the same reason that, you know this better than anybody, the benefits of self-funding have come way down market as a byproduct of, coalition style purchasing arrangements.
Captives, of course.
Captives and consortiums. And so I think that, we were talking about this earlier, like localizing care. Mm-hmm. There are organizations that do exist that are specifically there to negotiate between local employer groups, local community pharmacies, primary care. I don't know that standard mid-size employer is going to get a direct contract with the hospital system, but there's a lot of, as you obviously know, like bundled payment and direct contracting organizations where you can kind of hitch your wagon there. Yeah,
and then what would you do though, like in the emergency situation? That's the last step on that continuum, right? Like there are challenges in some locales or ones that don't really have competing hospital systems where they just won't accept reference-based pricing. They say no, you can't. We're not doing it. Sorry. Right. So then what do you do, right? How do you solve for that particular problem in your mind?
Well, it depends on the concentration of employees, I guess, and like just the accessibility, because I used this example with you earlier. I built self-funded health plans and am the co-founder of a healthcare navigation platform or benefits navigation platform. And I almost cut my toe off on my motorcycle and went right down to the most expensive private equity owned urgent care and paid $1,100 a stitch. So the consumerism part of the nature of the urgent stuff is, I guess, probably the last piece of the puzzle, because I didn't think at all about it, and I spend most of my waking life thinking about benefit navigation. So what we did in some scenarios, which I think is a kind of cool concept, particularly if we're talking about like on a geographic level with some relative proximity to one another, on-site shared clinics. We've seen even in like some urgent care environments, like some of our clients in Texas that were like oil field type risk profiles, if you engage the right organization or several of them are willing to participate in employer groups with some proximity to one another, they can share a clinic.
Yeah.
And it could be an urgent care clinic. And, that's assuming that there's enough proximity to make it there because, there's a balance between immediacy and, their ability to navigate.
Yeah, in an emergent situation, you're just trying to do your best to get the care you need in that moment.
That's right.
And sometimes we feel certain situations are more emergent than they are, but in the moment you think it's the only thing I need to do is right now is go solve this. And so fair enough, right? You're not necessarily putting your consumerism hat on all the time in order to do that. And I don't think that should be the expectation because if life and death are at risk, we don't want you to stop and open your HealthWallet necessarily and get a care navigation person.
I would advise that they don't.
I would advise they don't. Right? Like, is this what you call in and go, is this an emergency? Hang up and dial 911, right?
Although I would have to use that as a case study if somebody still pulled out HealthWallet when they cut their toe off, like that would be a prime member example.
See, they were even able to do this. Come on,
that's how easy it is.
It's that easy, yeah. But so, and maybe it is a false premise, this idea of trying to design a perfect plan because every one of them is individualized to that employer's needs, right?
Yeah.
But what I'm really trying to get at is, if, like, broadly speaking, what is the construct that seems to work the best today across the ecosystem, regardless of some of those constraints? And so I think we covered a lot of them, which is independent TPA most likely is the foundation. Probably independent stop loss carrier if we want to go up a step and say, don't have your stop loss carrier have association with the administrator and association with the PBM, right? So let's carve all three of those core components out, pharmacy as well.
Network.
And then from there, be intelligent about how you design the continuum of healthcare delivery with primary care, bundled surgery, reference-based pricing, potentially if possible. And then the last part of this equation, and then we'll finish the podcast, is what do we do when somebody does go to the emergency room for a really catastrophic event and get this enormous bill that we know most likely has some BS built into that bill, right? So like, does auditing or bill review come into the equation for you as well?
I think in an ideal health plan architecture, it certainly does. And it's not only on the front side, but it's also retroactively as well. So like claims audit and review. But, these organizations exist to try to steer folks to places where they've sort of already argued once and maybe reverse engineered into like a direct contract, but they're like, okay, you're willing to take that. Well, how about we send you people your way kind of thing? So I definitely think that, some sort of bill review is critical, but you got to determine where the optimal point is in terms of it being a cog in the wheel in the administrative process of the plan also, because a lot of TPAs are auto adjudicating claims under a certain dollar amount or whatever. And so, there are some out there that are focusing more on like specific maybe CPT codes or other things that are like areas of opportunity potentially.
That are maybe prone to fraud, waste, and abuse, like upcoding of kind of emergency codes, right? Those type of things, level 1 to 5, right? I had that firsthand experience, and I found out it's very common is to declare something more emergent than it actually is because there's financial incentive to do that for a hospital, right? So finding what those common sort of triggers are and being educated about how to like target those things, I think that's important, right? And so you can't stop people from consuming care. I talk about this all the time. Like we show a kind of a continuum of possible outcomes for a captive member. There's a continuum where there's literally 0% chance of it happening because there's 0 claims. And there's a continuum where almost 0%, which is the captive blows up, everybody hits their max and blah, blah, blah. That's not going to happen either.
Right.
But you can't get to a point where there's 0 claims consumption.
Right.
You don't want people not to go get healthcare, right?
Yeah, definitely.
So what we're trying to do is triage that as much as possible every step of the way to minimize the plan expense, and then also ensure obviously that they're getting the right care when they need it as well. And that's it, right? And if we do that, we create a much better version of what healthcare is.
And I think you can accomplish a lot of sort of like what it takes to wrangle in all of these cats if the care navigation unit is the brain trust of the plan. And so like, them operating under the guise of a member facing service unit. But like if they're the group that's executing on the plan level strategy and kind of doing the lifting on behalf of the membership in terms of just like the onus of consumerism, you can accomplish a lot more as a percentage of total if the navigation unit is kind of in lockstep with the strategy folks.
Yes.
And then, how do you get members into that environment is, where I know a guy.
$1 trillion problem.
Yeah.
Yeah, for sure, man.
Yeah.
All right, so let's do this then, and we'll kind of end the podcast here, Ryan. And as I usually like to ask, like, my guest perspective on kind of where the healthcare system, if you will, or this industry is going, right? And we don't have to sort of look at like a too long of a vantage point that's impossible to bet on. But like in terms of your business and what you're preparing for maybe in the next 1 to 3 years, what are some of the big things that you're preparing for in healthcare?
Well, definitely we're seeing them pull back the veil a little on kind of, where the bloat is in the health, in the healthcare system in the aggregate. And you see people like Cuban who are non-healthcare guys kind of getting in the game and at a minimum, like bringing some reasonable level of transparency to kind of what's going on behind the scenes. But, I have personally seen, I guess as a byproduct of the folks that we touch in our daily life and, running our businesses, there's a gravitation away from just standard commercial major medical.
Yep.
And I don't want to say that it's maybe that's not the best way to put it. It's not necessarily a gravitation away from it as much as there's a lot of alternative availability of things that, may look and feel very much like a major medical plan, but aren't necessarily a major medical plan. And so, we see a ton of like capitated style healthcare membership models and non-insured benefit solutions. But I think the reality is, the benefits of self-funding have come so far down market that without some serious change, I don't know how it's going to swing back the other direction.
No, I don't think so. I don't think people are now going to all of a sudden go running back to the fully insured market. I wish I remember the specific metrics, but I read a McKinsey study the other day, and it actually showed the flattening of growth in the fully insured market. It's almost stagnant. There isn't really any growth, but the self-funded market is growing by a few percentage points. But I think what that tells me is we're sort of at the precipice, at that tipping point right now,
right,
where it's going to be far more common to be self-funded for small groups than it is fully insured in the next couple of years. And I think we're just finally seeing the data catch up to what you and I probably kind of already know.
Yeah.
We're getting there. And I think the lawsuits and all the questions about fiduciary responsibility are helping drive some of that
Definitely.
interest. So is it a push or a pull? I don't know, but it's happening. That shift is happening.
Well, what I see too that's kind of interesting is we do a lot of work in the PEO and staffing world.
Okay.
And that's kind of just a byproduct of some of the like distribution relationships that we have, because they kind of serve that client profile a little. But what I've noticed about the PEO world is they're kind of like a micro representation of what I see going on in the macro, which is, they oftentimes have a fully insured master plan, but as that's starting to renew and at the trajectory that it has, they're starting to carve out independent level funded options. And as a byproduct of that, it's putting adverse selection back on the fully insured plan.
Yeah, of course it is. Yeah.
Right. And so as all the good risk leaves the market, that leaves only the bad risk in the fully insured world. Because, most people, when they, assuming they're even able to get their data, which, is a hurdle in itself coming from a fully insured world, the people that decide to go self-funded oftentimes are maybe a better risk profile than some of the others who could benefit from, somebody else taking 100% of the risk.
Yep.
In the macro, that's probably not good for fully insured.
Well, I would say on average, that is the case, right? On average, the groups that have a better risk profile on average will choose to self-fund. It doesn't mean somebody with a bad risk profile at this current moment in time couldn't benefit by seeing where the data, is driving those claims and then being able to address some of those drivers. I think there's still a benefit, but there's a breaking point where kind of the numbers they're not reasonable, even if you believe in the concept of self-funding. So I totally get that. But I do think I agree with your premise that the fully insured risk pool is going to start over time to retain more and more of the bad risk, because that's the main argument for staying fully insured is you can't go self-funded because you can't get to reasonable terms.
Right.
And so I think that's fair, right? I think that's going to happen. So then how does the industry respond to that, I guess, remains to be seen. But they have such a large market share that they're not just going to accept that type of leakage to continue forever.
Definitely.
Right?
And that's why they vertically integrate and buy facilities and buy the interoperability infrastructures and own PBMs and, you know.
Yeah, could you foresee a world, because the PBM world is one that you mentioned Cuban, but I see RFK mention it, I see Trump mention it. I do think there's some regulatory attention being placed on pharmacy. So do you imagine there'll be some regulation that comes down the pike in the near future?
I think that's the quickest lever to pull. Obviously, there's a lot of folks that have an interest on the other side of that deal. But, I feel like if you had to pick one of the major pillars of healthcare to where you could make a dent, that would probably be...
I would agree with you.
Yeah, that'd probably be the fastest.
Do you think, I think Elizabeth Warren, this is January 2nd, 2025, but I think recently she propositioned the possibility of breaking up not letting insurers own PBMs, right?
I think that would be smart.
I think it would be smart too. And I may disagree with her politically, but I think that's probably where we're at, is those two things shouldn't intersect.
They're eating their own dog food.
Exactly. Yeah. And you mentioned owning providers. That's another area where I think there's a real disconnect with you delivering care and insuring the care.
Right.
And you negotiating essentially with yourself in order to do what
and
those
then have
pricing
your loss
terms
ratios subsidized by the taxpayer.
Yeah. So those are the things that we just need to keep talking about it, right? But you don't know exactly what's going to happen, and we can't rely on regulation alone to solve those problems. I think right now, today, employers can solve it for their own population if they have a will to do that.
Yep.
Right? Okay. So anything else on the big picture of healthcare that you want to touch on, or should we just wrap up?
Well, I think that I know that all the people that you work with probably do this as a core business function, but just changing the mental paradigm from a 12-month insurance purchase to a healthcare purchasing strategy at the employer level is one that allows them to see further than how you can impact just 12 months. And I was actually talking to, I'll leave them out of it, but I have a large TPA customer that had one of their strategy guys speaking at SIA. And, there's all this cool cost containment stuff and bending the cost curve and all that. But how much can you bend the cost curve in 12 months?
No, I mean, you might be able to rip the Band-Aid off and solve some main drivers, right? But to get that sustainable, you have to have a longer term horizon that you'd make decisions on.
Because you can only impact unit economics to a certain extent that will materialize in a 12-month window. Right? So we would always, as on the consulting side, we would try to extrapolate 3 years out. And look at just current cost.
Well, that's how we show it, and I can't get into too much specifics, but that's how we look at it, is can we demonstrate savings over a 3-year horizon? But I think you hit the nail on the head. The industry has trained us all to think in 12-month cycles, because that's how we deal with renewals, right? And on spreadsheets especially, what are you looking at? Is you're looking at purchasing whatever insurance or stop loss insurance in a 12-month cycle, and then worrying about what's going to happen 9 months from now when you go try to procure it again.
That's right.
That doesn't enable you to make the decisions you need to make on your health plan that are actually going to effectuate long-term change, because you're solely focused on those 12-month increments of purchasing. And so you just got to change. Like you said, that's a mental paradigm shift that needs to change. The way that we all choose to consume healthcare and choose the strategy. It's not going to be done in a year.
There's no way.
There's no way.
Yeah.
I think it's a good way to end it. Maybe we'll just end it right there, man.
Sounds
but
good.
Ryan, I appreciate this. This is actually a lot of fun. I think this is the third time we've hung out, but I think I learned more today than I've learned in the past two interactions. So really appreciate you doing this, and I know the audience is going to benefit as well.
Thanks for having me, man. Appreciate it.
My pleasure.
Yeah.